The next disease that I had been promising you is Von Willebrand's disease. DAC was a bit complicated. Von Willebrand's disease will also appear complicated, but I shall make it as simple as possible for you people. It is a very important university question in which we fumble. Coming to the definition, it is a bleeding disorder caused by the quantitative or the qualitative defect of Von Willebrand's factor. Again, I repeat, it is a quantitative or a qualitative defect in the Von Willebrand's factor. It is usually an autosomal dominant disorder, but rarely can be autosomal recessive. Whenever we talk about Von Willebrand's factor, there is a factor 8 also. These two together form a complex. They have got separate origins, but then this complex is very essential for the clotting of blood. Factor 8 activates factor 10. And factor 8 is larger than the Von Willebrand's factor, and these two together form a complex. Hence, the deficiencies of these are interlinked. Therefore, any of these can lead to a bleeding disorder. So this is one of the important bleeding disorders we people should have in mind. Von Willebrand's disease. Factor 8, Von Willebrand's factor, and factor 8, Von Willebrand's factor complex. This is what we people should remember. This is the classical clotting cascade we always talk about. There is an intrinsic pathway and an extrinsic pathway. Extrinsic pathway is because of tissue damage, and then a series of steps are there. That is why it is called cascade. It is mainly mechanical. That is why I put M over here. Whereas here, it is chemostatic. So, factor 12, 12A, 11, 11A, 9, 9A, etc. and activation of 10, 10A. This is an intrinsic pathway, the blue color. The green color is the extrinsic pathway, and the yellow color is the common pathway. Ultimately, there is a formation of a fibrin clot. Since there is a cascade of events, any interruption at any one step will lead to a defective production or non-production of fibrin, leading to bleeding disorder. This is a basic concept that we people should have. And these are all A, which cause adhesion. So please do by heart. Earlier also I have shown you this. This is worth by hearting any number of times. A very important diagram from my book, one page. So this is the vessel wall. In the vessel wall, it is lined by endothelium or flattened cells. And there is a collagen over here, and low down there will be the muscle. Now what will happen is, whenever there is a loss of the endothelium, there is an exposure of VWF, Von Willebrand's factor. So it is subendothelial in location. Whenever there is a damage to the endothelium, it gets exposed. Once it gets exposed, the receptors, glycoprotein 1b, which are there on the surface of the platelets, get attached to the Von Willebrand's factor. This is called adhesion. Adhesion means attachment. Once there is an attachment, you find that the other glycoprotein 2b and 3a are activated, as a result of which more platelets get attached to each other. This is called aggregation. So there are two steps, adhesion and aggregation. And this will happen only when there is an exposure of Von Willebrand's factor. Otherwise, you and I will be having clotted blood throughout our vascular system. That doesn't happen. Now, what will be the manifestation? Because of a lack of the Von Willebrand's factor, this clotting doesn't take place. The patient can be having mucosal bleeding, increased amount of bleeding from the wounds, menorrhagia or menstrual bleeding, bleeding from the gums, hematoma, hemarthrosis, and so on it will go on. When there is going to be a defect in the Von Willebrand's factor. Please draw this. Another diagram depicting the same theme, you find that this is the vessel wall. These are the endothelial cells over here. There is a loss of the endothelium, exposure of the von Willebrand factor, the platelet gets attached. The first step is called as adhesion, and then fibrinogen helps. There are the other factors such as 2B and 3A, which result in aggregation of the platelets. So all this will happen. But when there is going to be a defect in the von Willebrand factor, there is no adhesion or aggregation. There are some conditions where giant platelets can be seen, which can also lead to defective coagulation. There are different types of von Willebrand disease. Kindly spend a little bit of your time, by heart it, it will fetch you marks. There are three types, type 1, type 2, and type 3. In type 1, there is a reduction of von Willebrand factor. In type 2A, there is a selective loss of high molecular weight multimers. Selective loss of high molecular weight multimers. In 2B, there are abnormally high molecular weight multimers and they are removed by phagocytosis. Ultimately, there is a loss. So in both these conditions, there is a loss of the high molecular weight multimers. And in type 3, there is a qualitative defect of von Willebrand factor. That is why in the initial introduction itself, I said it can be a qualitative or a quantitative disorder. This is the thematic diagram, again from my book, one page, a repetition. So this is the vessel wall, endothelial cell, loss of the endothelium is there, and then there is the exposure of the von Willebrand factor over here, and then you find that the platelets get attached. Platelets are usually very sober, harmless, but they can get activated. So they get attached over here, they lead to a series of steps such as factor 8, etc., which again promotes the clotting cascade. More of platelets are attached, aggregation. This will go on. This is a know-how. I would like you people to kindly understand it. You need not draw this diagram. So what is the pathogenesis? Again, a repetition, but it is worth it. Normally, you find that there is an endothelial injury. The subendothelial von Willebrand factor is exposed. Platelets attached by glycoproteins. Cascade for more attachment of the platelets. Activation of the factor 8. And then there is a clotting cascade that is promoted. And ultimately, there is a formation of fibrin. This is normal. But what will happen in a case of von Willebrand disease? There is a defective von Willebrand factor, which can be because of qualitative or quantitative deficiency or defect. So it does not function. Therefore, there is no platelet aggregation and the platelet patient has got bleeding diathesis. What are the investigations? One is restocytin aggregation test. Bleeding time is prolonged. APTT is abnormal. Sometimes you can do the bioassay of the platelets and find out whether there is any functional defect in the platelets. Rarely, von Willebrand disease can be acquired. So this can happen in conditions such as hypothyroidism, congenital heart disease, and lymphoma. And in these, you find that there can be antibodies against the high molecular weight multimers seen in von Willebrand factor. The treatment is you treat them with desmopressin or steroids, and the plasma derived from factor 8 concentrate, which is rich in von Willebrand factor, can be administered. As I told you earlier, the question that we omit is our university question. So,